full advantage of the time during the breakouts to connect with other attendees and families in the group breakouts in the lounge. While we're disappointed we can't be together in Pittsburgh as we originally planned, it's so nice to connect with everyone through video and spend time learning and growing together. We also want to share that the exhibit hall is now open, so we encourage you also to go in and visit with all of our vendors and sponsors and interact with their teams at their booths. So a few reminders and tips to help you navigate the virtual conference portal and have the best experience possible. Use the navigation bar on the left side of your screen to move around within the conference. The auditorium where we are now, the virtual exhibit hall, and the lounge where we have a robust calendar of more personalized sessions, including Q&As with Ultragenics, Reneo Pharmaceuticals, Dr. Jerry Vockley, and conversations for our teens and young adults. The lounge is also where all of the kids' activities will launch and go on the entire day. Be sure to be on the lookout for the Mitoman mascot, Mitoman. Find him through the conference space to earn points and be entered into a drawing for raffle prizes, including a custom Mito Action Lily Pulitzer scarf and tote, a doTERRA gift basket, and NeuroNeeds gift basket. Each attendee has a virtual briefcase. Some items are already loaded. Make sure you continue to add resources as you attend sessions and visit our sponsors and vendors. You'll be able to download all of the items in your briefcase. Make sure you visit the virtual exhibit hall and spend time interacting with our sponsors and vendors. There you can chat with members of their teams and more. If you have navigation questions, visit the help desk in the lobby, which will be staffed the entire conference. We'll take questions immediately following this morning's presentation, so we encourage you to submit your questions throughout the entire presentation using the Q&A at the bottom of the meeting screen. So this morning, we're thrilled to welcome Dr. Mark Korson. Dr. Korson graduated from the University of Toledo School of Medicine and completed his pediatric residency nearby at the Hospital for Sick Children. After his fellowship in genetics and metabolism at Boston Children's Hospital, he became director of the Metabolism Clinic at Children's until 2000. In 2000, he became director of the Metabolism Service at Tufts Medical Center's Floating Hospital for Children, as well as associate professor of pediatrics at Tufts University School of Medicine until 2014. Dr. Korson promotes an educational approach to address the growing crisis in metabolic health care due to the shortage of available clinicians to treat this patient community. In 2007, he co-founded the North American Metabolic Academy and an annual one-week intensive course about metabolic disease for genetic and metabolic trainees. NAMA is sponsored by the Society for Inherited Metabolic Disorders. Between 2007 and 2011, Dr. Korson directed the Metabolic Outreach Service based at Tufts Medical University, for which he traveled on a regular basis to 5 teaching hospitals in the northeastern US without an on-site metabolic service. In 2015, he co-founded the Genetic Metabolic Center for Education, a comprehensive multimodal initiative for improving the level of care for children and adults with metabolic disease. This past October, Dr. Korson joined VMP Genetics in Atlanta to promote healthcare metabolic consulting in order to assist physicians remotely in the care of their metabolic patients. He continues to develop innovative resources to help educate specialists and their trainees so they can participate more in the diagnosis and management of metabolic disease. Dr. Korson has been instrumental in advising Mito Action as we plan this conference, and he also is a member of the Mito Action Medical Advisory Board. Please join me in welcoming Dr. Mark Korson.
Thank you so much, and good morning. It's very exciting for me to be here. I've often found myself at the podium speaking to a live conference, but this is the first time I've really spoken in a virtual world. So while I've done online webinars, this is really the first conference, and I really celebrate Mito Action for showing this vision and taking this conference virtually. So today I'm going to be talking about protocols. So emergency protocols are pretty much a normal reality for patients and families with acute metabolic disorders, where they get into trouble and need help at home or in the emergency department. And they can be helpful, they can be life-saving. They are also not just treatment plans, they are also really need to be educational, because we as metabolic physicians can't be in the emergency room. We hope that the emergency providers will contact us, but they need something on site. We can't rely on them to find up-to-date information on the internet. So this is an opportunity to provide them with information that they can use right away, and for both diagnosis, but especially therapeutic purposes. So to begin, I want to give some background, because the background is essential. You have to understand the background for making sense of protocols. And because the protocols need to teach unfamiliar physicians about fatty acid oxidation defects, the content has to be clear about what fatty acid oxidation defects are. So just going to physiology. So the way the body works is through anabolism and catabolism. Anabolism are those biochemical pathways which promote the growth of the body, where there is more energy coming in from the outside than is needed for the body's biologic functions. And so that is a situation where a patient is normal, is growing, is healthy. And then there are situations of catabolism. Catabolism means there is less energy coming in from the outside than is needed, that is through either orally or intravenously or anywhere, but there's less energy coming in from the outside than is needed for biologic purposes. And so what the body then has to do is break down its own stores of sugar and fat and utilize them as sources of energy. So in the catabolic pathways, in those pathways where the body is breaking down its own stores of sugar, fat, and protein, that's where you're going to find the defects that are characteristic in, that are classic in metabolic disease. So the glycogen storage diseases, the fatty acid oxidation defects, the amino acid disorders, urea cycle disorders, organic acidemias, these are all defects in catabolism. And so what happens, because of that defect, certain compounds start to accumulate and the body can't do what it's supposed to do. What are triggers of catabolism? Well, these are any situation where there's simply not enough energy coming in from the outside. So prolonged fasting makes sense. During infection, most of the time we don't eat very well when we have an infection going on, especially if we have a fever. But we need actually more energy, not less, at those times, because the body is fighting an infection. Surgery is a situation where the body is injured and healing has to occur. And so in the post-surgical state, we need more calories, but often, again, post-surgery, we often don't eat well. Steroid therapy, steroid drugs they inherently promote catabolism. Vaccinations rev up the immune system, again, requiring more energy, and are often associated with fever, which makes everything in the body go faster, work faster, and needs more energy. And then there's the newborn period. Newborns are inherently catabolic. All newborns lose weight in the first week of life. That is catabolism. So when the body is breaking, what happens when the body breaks down or needs energy? Well, if you look at this picture, you see along the bottom an arrow signifying when a person eats a meal. And moving to the right of that, you see the time following that meal. So the energy source, seen off to the left, the energy source in the first 2, 3, 4 hours following a meal comes from the food that we eat. If we don't eat after that, then the body's going to need sugar from somewhere. And so it finds that sugar in stored glycogen, which is in our liver And the liver then breaks down that glycogen and sends out that sugar around the body. And that can last anywhere from 7 to 16 hours. If after that we still haven't eaten, then the body initiates two processes. One is gluconeogenesis, where it produces new sugar from substances that come from the muscle and red cells. And then later on, it starts to break down fat and change that fat into ketones. If after 12 or 24 hours, we still haven't eaten a meal, then the body spares muscle. It still continues to produce some glucose from red cells, but that's not enough for the body's energy needs. It's certainly not enough for the brain. And so the body switches over and utilizes fat as a primary source of energy. That fat is converted to ketones in the liver, and that's what the body utilizes after that. So fatty acid oxidation is an important energy producing process that occurs during long and very long periods of fasting. And so a fatty acid oxidation defect is a problem in the inability of a person to fast for long periods of time. So when the body is breaking down fat, that long chain fat goes from our fat tissue to the liver, and it has to cross over a membrane to get inside the mitochondrion of liver cells. It's escorted by carnitine through a series of 3 enzyme reactions. And once inside the mitochondrion, that long chain fat sits and has to be oxidized or broken down. The long chain fat is represented here by 16 yellow squares, each representing a carbon. And so what happens is 4 enzymes act upon that long chain fat and cut off a 2-carbon fragment called acetyl-CoA. 2 of those make acetoacetate, which is a ketone body. When we talk about ketones, that's what we're talking about. You have the rest of the long chain fat waiting to be broken down. And again, those enzymes cleave off another 2 and another 2 until that long chain fat is no longer long, but it's considered medium in length. And so then you have medium chain enzymes that cleave off 2 carbon bits until the medium chain length fat is now a short chain fat. And then you have short chain enzymes that finish off the job. So if you have a problem in one of those short chain enzymes, you may not have any symptoms at all, and that's often the case. But if you look, most of the fat has already been broken down. Since the long chain enzymes and the medium chain enzymes have been working. The brain is happy with that amount of energy, and so are the muscles. If you have a defect in one of the medium chain enzymes, that there is less energy produced from the breakdown of that fat. The brain is not happy because there is not enough energy generated in that situation. But the muscles gain enough energy so that they don't show symptoms when you have a medium chain fatty acid oxidation defect. If you have a long chain fatty acid oxidation defect, you don't get much energy out of that fat because one of the long chain enzymes is not working. That does not produce very much energy at all. The brain is unhappy and the muscles are unhappy. And this is what gives the symptoms associated with the fatty acid oxidation defect. So what is the nature of the problem in fatty acid oxidation defects? Well, certainly it's an energy problem. There's simply not enough energy coming from fat. But we also know it's a toxicity problem. The accumulating medium and long chain fat compounds that can't be broken down, that accumulate and hover around, they are toxic. They can be toxic to the brain. And I want to show you this. This is actually following the course of one child with MCAD deficiency who was studied by Dr. Charles Stanley at the Children's Hospital of Philadelphia. This is back in the 1980s. And on the lower part of the box, you see hours of fasting. So the fasting begins on the left and proceeds as you move to the right. That's the fast proceeds towards 32 hours. You notice that we measure free fatty acids and ketones on the left side of the chart of the graph, and glucose on the right side of the graph. So during the fast, you see that the patient's level of free fatty acids rises, moving from the left to the right. As the patient is fasting, he is mobilizing the fat from his fat tissues, and it's going to the liver, where it should be converted to ketones. But there you see the level of ketones. The ketones should be following the curve of the free fatty acids, but they don't. They sort of just hover there at the bottom, signifying that there's a disconnect between the oxidation or the conversion of free fats to ketones. And that is the definition of a fatty acid oxidation defect. Meanwhile, they were monitoring this patient's glucose, and the glucose was puttering along, but didn't become definitively hypoglycemic until the patient had been fasting for 32 hours. Now, at that time, it used to be thought that, oh, the reason these patients get tired and can go into coma is because they're hypoglycemic. But if that's the case, this patient wouldn't have developed symptoms until 30 or 32 hours. But this patient developed symptoms at around 14 hours, associated with the rise in free fatty acids. So this patient was suffering both an energy problem, but the accumulating fats that couldn't be broken down fully were also intoxicating his brain. So you have a situation where a patient is fasting then and develops symptoms somewhere into their fasting, into their fast. So here are situations where it might be important to utilize a protocol, whether at home or in the emergency department. So consider these scenarios. Scenario one, a patient is, say 10, 12 hours into a fast. Maybe it's an older patient. The patient is at home, but is otherwise well. But there are others who are sick at home and at school, but the patient himself is not sick. So that's when the clinic might get a call from the family saying, what do we do? In that kind of situation, it's probably just monitoring. Or you're at home, but the next day, the patient's going to have a procedure done and needs to be fasting after midnight or after 3 a.m. or 6 a.m. Again, it's going to be monitoring, planning and monitoring. You have another situation where the patient is at home and is getting sick, is developing symptoms of a cold, but he continues to eat. And so again, it's probably going to be a situation where you're going to monitor. And the protocol should dictate what to do in that situation. Another scenario is that patient is at home and is exercising or is going to exercise. And so there needs to be some sort of guidance as what that child should do to make sure he or she gets the energy necessary to exercise safely. And then there is the more concerning scenario, scenario 3, where the patient is outright vomiting. So the patient is vomiting, so has not been eating for a while, and can no longer sustain his blood sugar or his energy by himself, and may need to be admitted to hospital. Another scenario is the patient is fasting for a procedure or elective surgery is now in the hospital at the procedure, and so needs to be covered in terms of an energy supply. So with that as the background, let's talk about protocols. So the attributes of a good protocol. So I'm going to try something just to see how this works. So in thinking about what a protocol should do or should be, suggest one adjective that describes what an effective protocol should be using the Q&A feature. So, so throw out an adjective. So I'm hearing precise, clear, safe, actionable. Oops. Specific, detailed. All right. So I think this is probably coming from experience too, of things that have worked and things that have not worked. So good. We're on the same, oops. I'm trying to, okay, get out. Okay. We're on the same path here. So the attributes of a good protocol. One, it has to assume the reader is not familiar with the fatty acid oxidation defect. Don't assume anything. The protocol should explain the issues clearly, precisely as some, and in a detailed way, in a language that the reader understands. It has to offer practical advice. It can't be vague and meandering, but it should be open-ended. It shouldn't be so specific in its descriptions that it doesn't include what the patient is presenting with, who's sitting in front of the emergency room provider. But it also can't be vague. It should give enough detail so that the provider can see the symptoms and can see the concerns in that patient. And the protocol needs to end with a name, a signature, a contact number, and a date, because some providers will not recognize a protocol, especially if it's a non-specific protocol, like it's not customized for the patient. They need to see the patient's name, but they also need to see the provider, the metabolic doctor's name. And there needs to be contact information. So let's look at some emergency protocol. So another question. Have you encountered a situation in which an emergency department doc has not listened to you and what you know about fatty acid oxidation defects? Yes or no? Use the Q&A feature. So I'm hearing yes, 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 no. Okay, so this is potentially a problem. So you can be armed with a protocol, you can be armed with knowledge, and you walk into an emergency room and the doctor doesn't listen. Warning, some physicians are intimidated by patients and parents who know more about the condition than they do. If you think if you're in the emergency room with your child and things are not proceeding as they should, then one tactic is to have the emergency room doctor call your metabolic doctor. Now, they might say, I'm too busy, I can't do that. If that's not happening, then you call your metabolic doctor, call us, and let us know who we have to speak to, and we'll call the emergency room doctor, and then start to throw around, talk about what needs to happen, throw around terms like coma, like sudden death. That'll get things moving. Another tactic is to have the metabolic doctor run interference and call the emergency department before you get there. So they are waiting, they are armed with what they need to do, even if you have a protocol in hand. So the objectives of an emergency protocol, it provides essential information to the emergency room doctors in order to teach them. They have to know what they're dealing with, to inform about what symptoms the patient can present with. It has to direct their testing plan and their treatment plan. And it has to scare them a little because, and so, you know, if you ever read the emergency protocols, it is kind of scary, but we do it not to scare you, but to kind of scare the emergency room providers into acting. And then it also provides the clinician with contacts for backup. So the contents of an emergency protocol include information about the disease, about the sick patient, how to assess, how to test for, to gauge how unstable the patient is, and what's the first line of treatment. So this is one example of an ED protocol, and there are many variations, but this will provide an opportunity to make a few points. So we are going to focus on VLCAD deficiency just as an example, and I'm going to read this with you so I can highlight some points to you. So this is the background information. This is the teaching part. So VLCAD deficiency is a metabolic disorder caused by a defect in the beta oxidation of fatty acids. During longer fasting periods or when food intake is suboptimal, the body relies on its own stores of sugar and then fat converted to ketones as a source of energy. A defect in the ability to fully convert or oxidize fat into ketones is called a fatty acid oxidation defect. So the point here being that food intake is suboptimal and that there's an interruption in the body's ability to convert fat into ketones. So information about the disorder here. Affected infants and children usually present during the first year of life. Frequently, infectious illnesses, when feeding is poor or inconsistent, precipitate acute symptoms, which can include low muscle tone and weakness, profound lethargy or coma, with and or without hypoglycemia. Hepatomegaly, a large liver, and cardiac disease may be observed. VLCAD deficiency has been associated with sudden death syndrome. Look for a history of diminished oral intake or of similar acute episodes in the past, perhaps of lesser severity. Skeletal, that is the skeletal muscle is the muscle on your arms and legs, and cardiac muscle, you both use glucose and fat as primary energy sources. The inability to access either one during exertion can cause acute symptoms. This is particularly a problem in older children, teenagers, and adults when exercise can precipitate severe muscle cramping or pain, weakness, rhabdomyolysis, which is the breakdown of muscle, and myoglobinuria, the spilling of muscle protein into the urine. So repetition is very valuable in protocols because doctors skim protocols. So if they miss it in one place, they get to see it in another place. So the arrows are pointing out the importance of noticing or asking about the patient's eating, because again, these are defects in fasting. And so if the patient has not been eating well because they've been refusing to eat because of a sore throat or they've been vomiting, they are fasting. That's why they get into trouble. So you have a patient who, you're in a situation where you go to the emergency room and they look at the protocol and they see, oh, these disorders are associated with hypoglycemia. Your child isn't hypoglycemic. Your child can go home. Have you encountered this situation in the emergency department? Yes or no? All right. So, yes, this is not an uncommon situation. And that's why it's important repeatedly to note that there may not be hypoglycemia in a patient who presents acutely to the ER. If they're presenting to the ER, they might have started vomiting, but they're not yet in a crisis. They just have a vomiting from a GI illness. But if there's no intervention, that child may proceed and into a crisis. And so you want to stop it by starting an IV. Whether or not the patient is hypoglycemic, whether or not the patient is in a full-blown crisis, you want to prevent that. And so hypoglycemia is, of course, important to identify, but the symptoms can happen even if hypoglycemia is not present. So let's move on. Biochemically, acute crises are sometimes, but not always, associated with hypoglycemia. Again, repetition. At these times, the blood may show an unusually low level of 3-hydroxybutyrate. Similarly, the urine ketones measures absent or small. Both indicate an inability to synthesize normal quantities of ketones from long-chain fat. Liver functions might be elevated, and a coagulopathy, meaning a blood clotting issue, might be present. High ammonia levels can be present. CPK may also be elevated. That's a muscle enzyme. Chest x-rays may demonstrate an enlarged heart or a dysfunctional heart, and an EKG can show a rhythm problem. Important here, there are two causes for the symptoms during a VLCAD metabolic crisis: an energy deficiency. So it's that they've used up their glycogen stores, that they can't access fat, and a toxicity problem. So a child can be very sick and have a normal blood sugar. So it's a combination energy problem and a toxicity problem. So how do we assess? Or how should the doctor assess? The mental status. How awake is he? How sleepy? How responsive? Assess his heart and his breathing. The size of his liver. Assess hydration. Ask, when did the patient last eat or drink that is taken calories, and keep it down. Look for fever, infections, other stressors that might have triggered this decompensation. And then finally, at the bottom, assess for acute biochemical abnormalities. And this is noted in the next slide. But again, it's really important. These are defects in fasting, in not taking enough calories, catabolism. So investigating on admission to the ED, a bedside glucose level should be obtained. If the patient is lethargic or is otherwise symptomatic, the following tests can gauge the severity of the crisis. The blood sugar. These are normal tests that are available in any emergency room setting. Blood sugar, lights, bicarb, blood gases, ammonia, liver tests, CK, which is a blood muscle enzyme, and blood carnitine. In some cases, we measure acylcarnitines as well, but in most centers, those don't come back to help manage the acute setting, situation in the emergency room. So also, the patient is assessed by by looking at relevant tests for medical management. So doing an infection workup, looking for dehydration, and then of course the chest x-ray or EKG as necessary, calling the cardiology service if there are any concerns. So for access, if the glucose is normal and the patient's mental status is normal and he or she is taking oral fluids well, then there is no need for emergent IV access. If these criteria are not met, IV fluids are necessary, repetition, 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 regardless of the blood glucose level. If an IV infusion is required, a 10% glucose solution should be used with electrolytes, not only to treat and prevent hypoglycemia, but to counteract catabolism, which again is a major trigger for the metabolic crises in these patients. So finally, treatment in the ED. In the event of a low blood sugar value, especially when the patient is symptomatic or when the patient is lethargic or comatose with a normal glucose level, insert an IV, obtain the blood test, push a high glucose solution, follow with a continuous infusion of 10% dextrose. You might hear in clinic, you might hear from other parents about D10. This is 10% dextrose. It's a higher dextrose solution. And if you provide 10% dextrose at 1.5 times the maintenance rate for a patient, it is actually able to suppress catabolism, and so that the body will not dip into its fat stores as a source of energy. And then 2, when the patient is alert and has a normal blood sugar, there may not be a need for an IV at this time, but there remains a requirement for a regular enteral through the stomach supply of carbohydrates. Glucose and mental status should be monitored. Now, for VLCAD deficiency, this is very important. Number 3, supplemental calories should be given in the form of MCT, that is medium chain fat that bypasses the enzyme block in the disorder, or triheptanoin, which is a 7-carbon medium chain fat, which again bypasses the block. This can be therapeutic for defects in long chain fatty acid oxidation. In this protocol, this is a general protocol. This is not specific for a particular patient. As we'll discuss later on, one of the problems in protocols is that they're not updated. And so you're in the emergency room with old numbers and old doses of medications or nutrition supplements to be used. This protocol does not list the specific amount. That might be in a page that's appended to this protocol, and it's just the page that gets updated, but the protocol itself remains intact. Number 4, the usefulness of L-carnitine is controversial, and that really depends on the clinic, but there's some information there. Now, if the patient is admitted, here are some guidelines. These are not orders. These are just suggestions and ideas for the admitting physician to order to keep on top of the metabolic crisis. So it talks about a cardiology assessment to properly evaluate a patient. 2, in the event that the patient's muscles are damaged and there's muscle protein or myoglobin coming out of the urine, that needs to be followed carefully. Any precipitating factor like infection needs to be treated. The child may need to require continue ongoing sugar, MCT or triheptanoin. And then we avoid supplemental calories in the form of intralipid. Intralipid is IV lipid that is long chain. Long chain fat is obviously not the kind of thing that you want to be providing here. And then finally, at the end of the protocol, who is writing this protocol? How do we contact them? And what is the date? Because that, unless that is there, it might not be recognized by the provider. So the problems with ED protocols, protocols are not kept up to date. So you want to make sure that the protocol can stay intact, and then so at least it's useful. And then attach maybe patient-specific information to it. Other problems, ED providers don't pay attention, or it doesn't look official because it's not signed, or sometimes it doesn't lead to a phone call. Sometimes the emergency room provider is really relying on the protocol, but if a patient's situation becomes complicated, they continue to rely on the protocol and they don't call the metabolic doctor. That's where you come in as the patient or the patient advocate to get us involved. Moving on to sick day protocols. Why do we have home protocols? Because it can keep the patient stable at home without coming into the hospital, which is a potentially unsafe situation with infections and certainly now with COVID. And it allows the treatment team meaning you as the patient or parent and us as the metabolic service, it allows us to start and change treatment plans more quickly because we work together and you're able to implement the change right away. Who do we provide a home protocol to? Well, we have to, if the patient's metabolic crises are not generally severe. Some patients get into problems very, very rapidly, in which case there are questions, there are concerns about safety, about implementing a protocol at home if a patient's situation deteriorates so quickly. The course of a patient's metabolic crises are known and predictable. In other words, we have an idea, gee, it takes a while for Joey to get sick. We have to do this with the first few hours. Really, he doesn't really get into problems until the second day, that kind of thing. If you have an idea, if you have some experience with crises, then you feel a lot safer about using a protocol at home. And then the third criterion is patients or parents. The treatment team, the metabolic service has to understand, has to be confident that the patient or parents understand how to assess the patient's status, that they understand the protocol, that the protocol can be beneficial, but it has its limitations, and that they are good communicators and reliable. This is what the hospital team needs to see to feel comfortable providing a home protocol. So here's a general protocol, this one for MCAD deficiency. Again, I'll read with you. Your child has a metabolic disorder that is associated with acute episodes or crises where he or she can become acutely ill. If you are ever concerned about your child, call the clinic or the physician on call. The team can help you decide whether your child can be treated at home or needs to be evaluated in the emergency department. The numbers are there. You know your child better than anyone else. You know his or her typical routine and when she or he may be out of sorts. It is important that you pay close attention when he or she is not acting normally and convey these concerns to the metabolic team. You and your metabolic clinic staff function together as a team to best assess your child and determine a plan that is right for his or her well-being. So how can you assess? And this is the most important part of the protocol. Consider these questions. Is your child exhibiting any of these? Nausea or vomiting, refusing to eat or drink. Remember, these are defects in fasting. Fever, signs of infection, which are triggering the crisis. Pallor or sweating, maybe associated with a low blood sugar. And then what is the patient's mental status? Sleepy, lethargic, unresponsive. Is there a trigger for your child's symptoms? What might have stimulated this trigger, this crisis? An infection, exposure to an infection, stomach problem, a vaccination with fever, or something else. And then, very important, we need to hear this from you. How has your child been eating? Has there been a change in the amount, in the regularity of eating? How long is he going at night without any food or drink? Does he or she get normally a snack at bedtime or during the night? And is he or she still taking it? And when was the last time she ate or drank and kept it down? Because we're trying to gauge how close to trouble your child is in. And then just asking about medications in case he or she is on it. And then again, there will be specific information here that is customized for your child, but, and this is the important part that is underlined, this treatment plan is customized for your child and should only be implemented after you discuss your child's status with your metabolic clinic team. And then again, the information there with signatures, dates, and contact information. The problems with the home protocols is that sometimes they're not kept up to date. The child is grown and doses for things and volumes for things have not been kept up to date. Other problems, that patients or parents implement the protocol or make changes without calling the team. Oh, we've seen this happen before so many times, and so we don't call the clinic and we're just going to get it started and see what happens. Well, when that happens, the treatment team becomes uncoordinated. You're doing something without the metabolic team knowing what's going on. If the child gets worse, the team doesn't know what's going on. And so you find yourself in a situation where you start having to backtrack, and it may precipitate a hospitalization. So please contact the team. And then finally, sometimes the nutritional plan is disrupted. That a child, so we've seen children who have been on sick day protocols for so long that it really has altered their nutrition. I used a sample metabolic protocol, but they do exist online, and one source for protocols is at the New England Consortium of Metabolic Programs. This is their website. And if you notice off to the left, it says for professionals, acute illness materials. That can be a source of protocols for your physician to use as a basis. These are not just ordinary standard things. They really do need to be customized a little to your situation or your child's situation. So at that point, I will stop and I will take questions.
Thank you, Dr. Korson. That was great information. So we've got a few questions that have come in. The first one is, can medium chain fatty acids join together in the mitochondria to make a very long chain fatty acid?
No. Fat is stored as long chain fat in fat tissue. When oxidizing, long chain gets in the liver, gets shortened to medium, gets shortened to short. There's a completely separate, and that occurs in the mitochondria of the liver. There's a completely separate biochemical pathway where fat is built from short to medium to long chains. That is, and then stored. That occurs in a completely separate biochemical pathway and is unrelated to these defects.
Okay, great. Thank you for that question. Next question is, we've spoken with EMTs who are blown away that our child could have rhabdo without hypoglycemia. How do we explain this to them? Is it because he's not yet in a crisis, as you mentioned?
Well, I mean, welcome to the world of metabolic medicine, where you know more about a disease than 99.9% of the providers that you will encounter. So it behooves you to learn because you're going to have to teach. So I think you have to go back to basics and say, this is an energy problem, that muscles use sugar and fat as an energy source. My child has a problem with utilizing fat as an energy source. The sugar isn't a problem here. And so muscles can get into a problem whether or not the blood sugar is low. So, I think that's the way I would approach it. Keep it simple. And it's just keep repeating. And if you find that they're withholding treatment, get us involved.
Okay, great. The next question is talking about encouraging clinicians to take the letter seriously. And this attendee is asking, what are the ways in which the patient community and advocacy groups can help to encourage clinicians to understand the importance of these protocol letters?
It's easier to do. It's easier to do with physicians that you see regularly. If you're seeing a physician on a regular basis, like your family physician, your pediatrician, show them the protocol when your child is not sick, and go over the protocol at that time. It's always a problem to introduce information, especially someone else's protocol, under emergency situations. At that time, the doctor's already stressed out. The doctor doesn't know very much about these disorders. You're presenting some information. Some doctors will accept that readily and be very appreciative. Some doctors will say, what is this information? Where does it come from? And they're having issues with trust, regarding its credibility. So where possible, go over the protocol in advance when you or your child is not sick. And if they have any questions, then you can deal with them then. If they want to talk to somebody, your metabolic doctor, about that, or it doesn't even have to be your metabolic, any metabolic doctor, then they can prepare. So again, they're ready in the event of an emergency situation. in the emergency room where you're not, where you're in a crisis situation and you really need them to get on board, it's a little bit of a problem. So I think what I would do is tell them that reinforce your child is followed by a metabolic doctor. That doctor is an expert in these disorders. That doctor put together this protocol for my child and is happy and is interested in talking to you about this if you have any questions about the protocol. I think that's really the only thing you can do. Push names, push institutions, mention, where your child is or where you or your child is followed. And then again, if you encounter resistance or you encounter problems with belief, then really it's not worth arguing. I think it's worth just going and getting backup, getting a metabolic doctor involved.
Great. And one of the things you mentioned is that, making sure that those protocol letters look official. So does that mean being on letterhead from your physician's office, or what to you when someone walks in with a letter like that, what makes that official? So
yes,
that, those are simple things, but clearly that matters.
Yes, it is important if they're going to take it seriously, because those things may end up in the medical record. And so, yes, I would put it on letterhead. Where possible, put the patient name. The patient name should be there with the date of birth, and there should be a signature with a name, with the contact information, and a date. And that should probably be updated every year.
Great, thank you. Last question. What are your suggestions on helping to explain the difference between growing pains and rhabdo?
So growing pains fall into the category of a diagnosis of exclusion. In other words, you have to rule out everything else, especially if you're dealing with a patient who has a fatty acid oxidation defect. You have to always consider symptoms that are known to be associated with that disorder. So you always have to consider the possibility of rhabdomyolysis. Only once you've ruled that out can you consider this vague, non-specific, unprovable term like growing pains.
Mm-hmm. Okay, great, thank you. So that ends this presentation. Thank you so much, Dr. Korson. It's so important for families, to be prepared in the event of a medical episode, to be armed with the tools and everything that they need to be able to advocate for their child. So we really appreciate you sharing all of this information. Just want to remind everybody that Dr. Korson will be joining us again this evening at 6 o'clock to kick off the Magic Bracelet film. Dr. Korson was the medical advisor for the film, and he managed the care for Rena, who is the Mida warrior whose story and vision came to life through the Magic Bracelet. So we encourage you all to join us this evening for that film. And we will sign off. The next session will be with Dr. Georgianne Arnold to discuss newborn screening. And we will get started with that session in just a few minutes. So thank you, everybody. Dr. Korson, we really, really appreciate you and all that you've done to ensure that this conference could take place. So we really, really appreciate you. Thanks, everyone.